Hello, everyone. I am Deep Datta. I'm an endocrinologist based in Dwarka, New Delhi. Before starting my presentation, I would like to thank our editor-in-chief, Professor Dr. Anup Mishra, of our journal Diabetes and Metabolic Syndrome Clinical Research and Reviews, and our associate editor, Dr. Ritesh Gupta, for selecting our paper as one of the best review articles published in this esteemed journal. In the next 7 minutes or so, I shall be presenting before you the first meta-analysis ever published on the efficacy and safety of lusiogliflozin, an SGLT2 inhibitor, which is very popular in Japan. And we are going to look at their efficacy and other pleiotropic benefits and potential side effects with regards to managing type 2 diabetes. I'd like to thank all my co-authors shown in this slide. We as a team worked together, and it made us do this meta-analysis because we all know it's a highly labor-intensive job. This is the abstract which I got from the PubMed Central. So if you look at the key points of our meta-analysis, we analyzed data from 10 randomized controlled trials from 1,300 odd patients with type 2 diabetes who were managed with lusiogliflozin. Now, the standard dose for lusiogliflozin in managing type 2 diabetes is around 2.5 milligrams per day. And in patients, the guidelines say that those who are not able to achieve the glycemic targets, we may increase the dose to 5 milligrams per day. So when we look at the data, I shall come to later in different slides how this molecule performs as compared to placebo and as compared to other peer anti-diabetes medications. If you look at the data with regards to compared to placebo, very impressive data. The HbA1c lowering with the standard dose of 2.5 milligrams of lusiogliflozin was an additional 0.76% as compared to placebo, which translated into a average fasting blood glucose reduction of around 27 milligrams per deciliter as compared to placebo. A very impressive blood pressure lowering. If you see, the average systolic blood pressure lowering was pretty good as 4.19 millimeters of mercury. If you look at the body weight loss, we know it's a class effect, mild weight loss, and it was replicated with lusiogliflozin also as compared to other SGLT2 inhibitors. In this study, as compared to placebo, we found that there was around 1.6 kilograms weight loss. There was a beneficial impact on serum uric acid levels, which came down slightly, and the liver enzymes also came down slightly. Again, these are well-known properties with use of SGLT2 inhibitors because of their beneficial impact on different components of metabolic syndrome. What really concerns us with the use of this class of drug is the risk for genital infections. And at least in the data coming from clinical trials, it was not significantly increased in patients receiving lusiogliflozin as compared to placebo. So now what is this molecule? Let us look at this molecule. We have got so many SGLT2 inhibitors available in the country. So how is this molecule different compared to others? Well, this is a molecule which is being in clinical use in Japan since 2014. So it's almost going to be now 10 years of use of this molecule in the clinical practice. And let me share with all of you that it is one of the top 5 prescribed SGLT2 inhibitors in Japan. Not only that, if you look at there's a paper which looked at the prescription patterns because everything is digitally recorded in Japan. They found that in terms of quantum of growth, this is the third fastest growing prescription of lusiogliflozin as compared to other SGLT2 inhibitors. The only 2 other SGLT2 inhibitors which are growing faster in Japan is empagliflozin and dapagliflozin. So it is a molecule with relatively long half-life. So it needs a once-a-day dosage, if you can see on the right side of the screen. And we all know that this is a molecule which causes glycosuria, we all know. So we would love to know how it performs in different stages of renal dysfunction. So yes, we have published data from clinical studies which have shown that the glycosuric property of this molecule is maintained predominantly at GFR above 30 ml per minute. Please look at the data. The moment GFR goes less than 30, the 24-hour urine glucose excretion actually came down to only 35 grams and 21 grams as compared to nearly 80 or 90 grams for people having GFR more than 30. So I think, again, we all know as the GFR comes down, and the potency to secrete stuff through the kidneys obviously also comes down. As with all the peer rules and guidelines, we did write a proper protocol before we did this meta-analysis. It was published in the Prospero, having a dedicated registration number. Since our primary outcome was to look at reduction in HbA1c, and we know at least we need 3 months of follow-up to see a meaningful change in HbA1c. One of the major inclusion criteria for our meta-analysis was that we took studies which had at least 12 weeks or 3 months of follow-up, or else we did not include those RCTs. Again, I would like to highlight, we focused data only from RCTs. We did not take data from case control studies, from real-world studies, from observational studies. An initial literature search of different databases, we came up with 151 articles. With rigorous standardized search and coming out exclusion of articles, we came down to 10 RCTs. And then we again did a subgroup analysis of the 10 RCTs. 6 had placebo control groups, and 4 RCTs had active controls, which compared luciogliflozin with other approved anti-diabetes medications. So what were the different active controls in different RCTs? One study used voglibose 0.2 milligrams thrice a day. Of the 2 studies, they used different DPP-4 inhibitors ranging from vildagliptin, teneligliptin, sitagliptin, linagliptin, and alogliptin. And the 3rd study used 1000 milligrams of metformin per day as compared to luciogliflozin 2.5 milligrams per day. So a pretty good dose of metformin was used. Now let us come to the key outcomes of this study. This is the grading of the main outcomes of this study. That's important. We use the GradePro GDT software. It's an online validated tool to grade the main outcomes or results of your study. We all know that higher the baseline HbA1c, greater would be the reduction of HbA1c. So when I just mentioned some time back that the HbA1c reduction was around 0.76% with luciogliflozin, we must remember that the baseline comparative HbA1c in the placebo group was 7.7%. So it's actually a pretty good glycemic efficacy, having a 0.76% lowering of HbA1c from a baseline of 7.7%. It's a pretty good patient. Most of the patients would end up achieving the glycemic targets of less than 7% HbA1c. Similarly, the blood glucose lowering around 27 milligrams per deciliter came at compared to a baseline of 157 milligrams per deciliter in the control group. Again, a very impressive blood pressure lowering. So I think the point has to be kept in mind. If patients are using other antihypertensive medications, we may have to reduce the dose or change the dose of those medications. Again, a uric acid lowering property has been known to be class effect of SGLT2 inhibitors. And again, it was beautifully seen in our meta-analysis. And of course, other beneficial impacts on different components of metabolic syndrome, like reduction in triglycerides and liver enzyme levels. If you look at the level of evidence, the grading, most of the evidence had a high grading of evidence, highlighting that the RCTs were of pretty good quality. They were very minimal heterogeneity, and there's a very good chance that the results noted in this meta-analysis are going to be replicated in the real world scenario. If the grading score was low, then in that case, we are really not sure whether the results of this meta-analysis could be replicated in real world, but that is not the case, at least with this meta-analysis on luciogliflozin. Now let's just scan through the different forest plots which we generated with regards to the use of luciogliflozin. If you see the 3 major outcomes, the HbA1c, the primary outcome, and the 2 secondary outcomes, fasting glucose and post 2 hours postprandial glucose. If you see the left side compared to placebo, right side active control, if you see compared to placebo, very good. All the graphs are less or towards the left, it's not crossing midline, statistically significant observation, and the results tend to be similar. Of course, when you compare to active controls, the HbA1c reduction was not significant, but tending towards luciogliflozin. But if you look at the fasting blood glucose, somehow it performed so much better with luciogliflozin as compared to the active agents in different RCTs used, which was voglibose, metformin, and different DPP-4 inhibitors. Now, very important to look at the safety data, very reassuring. There was no significantly increased occurrence of total adverse events or severe adverse events or in risk for hypoglycemia. Genital infections were not statistically significant. Euglycemic ketosis is a well-known complication in people receiving SGLT2 inhibitors. So at least in the clinical trial setting, no increased occurrence of urine ketone bodies were noted in any of the clinical trials. Also, occurrence of volume depletion, thirst, postural symptoms were not noted to be increased with the use of this molecule as compared to the controls. So in general, at least from clinical trial data, this molecule was pretty well tolerated. Now, when we talk of the 5 milligram dose, unfortunately, data is very less. Only 2 RCTs actually use the 5 milligram dose. So that the use of this dose cannot be routinely recommended in clinical practice. I think 2.5 milligram per day would be the standard and the most commonly recommended dose for use of luciogliflozin for managing type 2 diabetes. Now, some major limitations. We don't have any long studies looking at the long-term CV outcome. It's just not there. All the trials which we include in our meta-analysis had around 6 months of follow-up, 3 to 6 months of follow-up. So long-term data, the glycemic efficacy is very good. What about glycemic durability? We need more trials, we need more data. A good amount of real-world evidence has been published, which has shown a good durability over 1 to 2 years of clinical use, but they're real-world data, not clinical trials. There are no dedicated CVOTs, but there are small studies which have shown that there is significant reduction of epicardial fat with the use of lucigliflozin. Now, epicardial fat is known to be a very important predictor of cardiovascular events. So, good a surrogate informant in certain surrogate markers of cardiovascular events. Again, there's a study by HD et al. Which showed that there's a significant reduction in BNP levels in patients with heart failure with preserved ejection fraction receiving lucigliflozin. But again, long-term data on how hospital admission for heart failure, as seen with other agents, is not available with lucigliflozin. An important study which is currently ongoing with lucigliflozin, we will see the data very soon in another 1 year, is the combination of lucigliflozin 2.5 milligrams with injectable semaglutide of half the dose, which is 0.5 milligrams per week, in improving different aspects of metabolism-associated fatty liver disease. So with this, I would like to end my presentation. Thank you so much.